Ancient Egyptian medical texts, the Ebers Papyrus, dating to around 1550 BCE, mentions the connection between gum diseases and systemic health, showing that this link was recognized thousands of years ago. In the early 20th century, Dr. William J. Mayo observed that patients with diabetes were more prone to gum diseases, highlighting the importance of oral health in diabetes management. Famous stories illustrating the link. President Abraham Lincoln's dentist records from the 19th century revealed that people with diabetes often had severe gum disease before insulin was discovered. Gum infections were sometimes an early clue to hidden diabetes. Dr. Lowe's landmark study in the 1960s in Norway showed that when oral hygiene stopped, gum inflammation quickly worsened, especially in people with diabetes, pioneering the recognition that blood sugar control directly affects oral health. Wilford Brimley, the American actor and diabetes advocate, openly discussed how gum disease complicated his diabetes management, raising public awareness that controlling both conditions is essential. Bob Krause is one of the longest-living individuals with type 1 diabetes. His story is a testament to rigorous self-care, including oral hygiene. Despite decades of insulin therapy, he maintained good dental health by prioritizing regular cleanings and managing blood sugar tightly. Jill Wright, diagnosed at 22 months. Jill has lived with type 1 diabetes for over 60 years. She shared how gum infections in her 30s were a wake-up call to improve her oral hygiene and blood sugar control. Her dentist was the first to notice signs of inflammation that correlated with her fluctuating glucose levels. Dr. Barbara Boucher, a consultant physician and diabetes researcher, raised awareness about diabetes among Asian communities in Britain. Her research linked vitamin D deficiency and betel nut chewing to increased diabetes risk and oral complications. While there aren't many widely publicized personal anecdotes from celebrities or historical figures, specifically detailing their struggles with both diabetes and gum disease, the connection has been illuminated through landmark scientific studies that have become famous in medical literature for establishing the bidirectional link. For instance, the Columbia University study from 2006, which revealed that diabetes can lead to gum disease in childhood onset cases much younger than previously thought, challenging earlier assumptions about the timeline of oral complications. The 1988 to 1994 U.S. National Health and Nutrition Examination Survey, NHANES III, data which demonstrated that individuals with poor glycemic control, HbA1c 9%, had a significantly higher prevalence of severe periodontitis with an odds ratio of 2.90, and highlighted how periodontal disease doubles the risk of insulin resistance. Longitudinal studies from the Gila River Indian community, which showed that severe periodontitis in people with type 2 diabetes increased the risk of complications like macroalbuminuria 2.0-2.6 times higher and end-stage renal disease 2.3-4.9 times higher, underscoring the deadly interplay and influencing modern integrated care approaches. These studies have shaped clinical guidelines and public health awareness, much like famous narratives in other fields. Basis of the relationship. The relationship between diabetes and oral gum diseases, primarily periodontitis, is bidirectional. Diabetes increases the risk, severity, and progression of periodontitis by 2-3 times, while untreated periodontitis worsens glycemic control and diabetes complications. Physiological reasons. Diabetes promotes a chronic inflammatory state that exacerbates periodontitis by impairing wound healing and tissue repair in the gums. High blood sugar leads to microvascular changes, such as thickened basement membranes and reduced blood flow to periodontal tissues, similar to those seen in diabetic retinopathy or nephropathy. This results in heightened local inflammation, with elevated levels of pro-inflammatory mediators like prostaglandin E2, PGE2, and interleukin-1b, IL-1b in gingival crevicular fluid, especially when HbA1c exceeds 8%. Neutrophil function is compromised, with defects in chemotaxis and phagocytosis, leading to prolonged inflammation and greater destruction of the periodontal ligament and alveolar bone. Conversely, periodontitis contributes to systemic inflammation, raising serum C-reactive protein, CRP, and IL-6, which can impair insulin signaling and worsen diabetes control. Endocrine reasons. Endocrine dysregulation in diabetes, such as reduced insulin secretion and action, fosters a pro-inflammatory environment that heightens periodontal susceptibility. Adipokines like TNF-A, Illinois, 6, and leptin from adipose tissue amplify inflammation, particularly in type 2 diabetes with obesity. Hyperglycemia promotes advanced glycation end products, AGEs, that bind to receptors, RAGE, upregulating cytokines and causing fibroblast apoptosis in periodontal tissues. Periodontitis, in turn, propagates insulin resistance through systemic cytokine release, with studies showing correlations to diabetes complications like retinopathy. Treatment of periodontitis can reduce TNF-A and CRP, improving endocrine balance and HbA1c levels. Metabolic reasons. Metabolic alterations in diabetes, like hyperglycemia, impair osteoclastogenesis and bone formation, while enhancing osteoblast apoptosis, accelerating bacteria-induced bone loss in the jaws. Poor glycemic control directly correlates with periodontitis severity, as high glucose fuels oxidative stress and matrix metalloproteinase, MMP, release from neutrophils. Obesity exacerbates this via insulin resistance, linking type 2 diabetes to greater periodontal destruction. On the flip side, periodontitis increases metabolic burden, raising risks for cardiorenal mortality, 3.2 times higher in diabetics with severe disease, by impairing insulin sensitivity. Genetic polymorphisms in lipid metabolism genes further tie the conditions together. Bacteriological reasons. Diabetes alters the oral microbiome, favoring pathogenic bacteria like Porphyromonas gingivalis, Tannerella forsythia, and Aggregatibacter actinomycetum comitans, which thrive in high glucose environments and drive biofilm formation in periodontal pockets. This leads to dysbiosis with higher P. gingivalis counts in uncontrolled diabetes, prolonging inflammatory responses. Periodontitis may influence diabetes bacterially via swallowed pathogens, affecting gut microbiota, as seen in mouse models where induced periodontitis raised blood glucose by altering intestinal bacteria. Bacteria like Silanomonas noxia are linked to obesity and insulin resistance. Medical reasons. Medically, diabetes is a major risk factor for periodontitis, with epidemiological data showing a threefold increase in susceptibility, compounded by shared risks like smoking, obesity, and immune compromise. Type 2 diabetes elevates periodontitis risk by 34%, while periodontitis predicts poorer HbA1c control, 9%. Treatment is interdependent. Periodontal therapy improves glycemic control, for example 0.4% HbA1c reduction, and diabetes management curbs gum disease progression. Genetic factors such as interleukin polymorphisms increase shared susceptibility. How to achieve good control of blood sugar and gum health. Controlling blood sugar and maintaining gum health requires an integrated approach focusing on diabetes management, oral hygiene, and regular professional care. Blood sugar management. Keep blood glucose within your target range as set by your doctor to reduce inflammation and improve gum healing. Follow a healthy meal plan developed with your doctor or dietitian, emphasizing balanced nutrition to stabilize glucose levels. Use diabetes medications as directed. Monitor blood sugar regularly, especially before and after dental procedures, and adjust as needed with professional guidance. Incorporate regular exercise and maintain a healthy weight to enhance insulin sensitivity. Quit smoking or tobacco use, as it worsens both diabetes control and gum disease. Seek support from quitlines or resources like smokefree.gov. Gum and oral health. Maintenance. Brush twice daily for 2 minutes with fluoride toothpaste and a soft bristled toothbrush, manual or electric, using a 45-degree angle to clean all tooth surfaces and the gum line. Floss daily, or use interdental devices to remove plaque between teeth and under the gum line. Curve floss in a C shape around each tooth. Visit your dentist at least twice a year for checkups and cleanings. Those with diabetes may need visits every 3 months or more frequent. If gum issues are present, inform your dentist about your diabetes history, medications, and recent blood sugar levels to tailor treatments. Address dry mouth by chewing sugar-free gum, using mouth gels, or sucking on sugar-free candy to stimulate saliva. Seek immediate dental care for symptoms like bleeding gums, swelling, loose teeth, dry mouth, or bad breath. If anxious about dental visits, communicate with your dentist to adapt procedures. Consider antibacterial mouth rinses or antibiotics if recommended by your dentist for infection control. O. Explore affordable care options like community health centers or Medicaid if cost is a barrier. Consistent adherence can break the cycle. Better blood sugar control reduces gum disease risk, and healthy gums support stable glucose levels.